that will
Diponegoro University in Semarang.
Oh, Semarang.
3 tahun, Jogja, Solo, Semarang on Central Java.
Oh, okay.
On Central Java Province. Yes. 11 Maret University in Solo and Gajah Mada University in Jogja and Diponegoro University in Semarang. All of town in Central Java. Yes.
Usually we call Joglo Semar, Prof. Because
it's like
Joglo Semar.
Joglo Semar.
Yeah, Jogja, Solo, Semarang. Because in the final research, we will present it to the Jogja and Semarang staff too. If our resident have a final research, they will present the final result in what we call it, regional exam. Regional exam.
Yes, regional, like states, like they have a different.
Yes.
Yeah.
And in Sebelas Maret University, how many postgraduate students, ENT?
For now, we have 25 residents, Prof. Because our staff is only about 8 staff.
And then
minimum.
All of them in campus, or they are out campus as well, the postgraduate students?
Mainly in campus.
In campus?
Because this is still on the pandemic, so we didn't do out campus activity yet.
Oh, okay.
Prof, can we start this session?
Yeah.
Okay.
We can start, right? Can I share screen?
Okay, Prof. We will try to contact our Vice Dean because he will give a welcome speech. Wait for a minute.
Once it's okay, then I will share screen on my side, right? So I will do on my side.
Prof, we will have opening ceremony first, and then the lecture will start.
I unshare the screen.
Selalu di hati terukir pasti tak akan terganti. Kita berjanji berjuang di sini hingga terbukti segala mimpi. semua berjalan dan kita telah putuskan kita akan berjuang di sini tempat ini. Tentukan arah dan terus melangkah, jangan menyerah walau raga lelah. Kita adalah manusia biasa yang punya rasa dan punya asa. Selalu di hati terukir pasti tak akan terganti. Kita berjanji berjuang di sini hingga terbukti segala mimpi. Akan goyah walau kadang resah, pergilah bunda, sambut hari cerah. Kita akan buktikan, kita akan bertahan di sini tempat ini. Tentukan arah dan terus melangkah, jangan menyerah walau raga lelah. Kita adalah manusia biasa yang punya rasa dan punya asa. Bukan solo selalu di hati terukir pasti tak akan terganti. Kita berjanji berjuang di sini hingga terbukti segala mimpi. Terus melangkah, jangan menyerah walau raga lelah. Kita adalah manusia biasa yang punya rasa dan punya asa. Bukan solo selalu di hati terukir pasti tak akan terganti. Kita berjanji berjuang di sini hingga terbukti segala mimpi. Segala mimpi.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Good afternoon to Professor Dr. Salina Husain as our speaker today. Good afternoon to Dr. Paramasari, PhD, as the Vice Dean for Academic and Student Affairs of Faculty of Medicine, Sebelas Maret University. And also good afternoon to Dr. Sarwastuti Hendra Dewi, Otorhinolaryngologist Consultant, as the Head Department of Otorhinolaryngology, Head and Neck Surgery. Dr. Hadi Sudrajat, Otorhinolaryngologist Consultant, as the Head of Study Program, Otorhinolaryngology, Head and Neck Surgery. Dr. Dewi Pratiwi, Otorhinolaryngologist Consultant, as our moderator today, and all of the audience attending today's lecture. I would like to introduce myself. I am Dita, the resident of Otorhinolaryngologist, Head and Neck Surgery, Sebelas Maret University, and I will be your host today. It's such an honor to welcome you in our international guest lecture. Today, we're going to have a very special speaker from Universiti Kebangsaan Malaysia, Professor Dr. Salina Husain, and she will present about smell disorders. What's new? Well, this is very interesting because nowadays, during the pandemic, the smell disorders have much been discussed. So now I would like to read the agenda of today's lecture. First, we will listen to our national anthem, Indonesia Raya, continued by March UNS. Second, we will have the video profile of otorhinolaryngologist Head and Neck Surgery of UNS. Next, we will have a welcome speech by as the head of study program Otorhinolaryngology Head and Neck Surgery of UNS, and then followed by opening speech by Dr. Paramasari Dirgahayu, PhD, the Vice Dean of Faculty of Medicine, Sebelas Maret University. Next, the primary agenda is an expert lecture by Professor Dr. Salina Husain from Universiti Kebangsaan Malaysia. This session will be followed by panelist discussions and Q&A session. And the last is closing. Okay, without further ado, let's moving on our first agenda. We will listen to our national anthem, Indonesia Raya, continued by Mars UNS.
Universitas, Sebelas Maret kami di bawah panci Pancasila, di dalam kiprahnya tridharma, pedomannya dengan tepat semangat yang memajang demi keagungan dan keluhuran alma mater 11 Maret, alma mater tercinta. Sebelas Maret kami tegakkan langkahmu. Universitas, Sebelas Maret kami semoga jaya selama-lamanya.
Next, please allow us to share you briefly about Otorhinolaryngology Head and Neck Surgeries Study Program, Sebelas Maret University.
Program studi THTK LFK UNS sudah ada sejak tahun 2005. Sejak didirikan oleh para pendahulu kami, prodi ini tumbuh dan berkembang dalam berbagai aspek, baik aspek akademis maupun non-akademis.
Visi KL yang profesional, berwawasan komunitas, dan mampu bersaing secara internasional pada tahun 2027.
Untuk mensukseskan visi tersebut, kami dari bagian THTKL FKUNS Rumah Sakit Dr. Moewardi berupaya menyelenggarakan pendidikan kedokteran spesialis THTKL yang bermutu, menghasilkan lulusan yang profesional, berwawasan internasional, dan berorientasi pada komunitas. Kemudian, mengembangkan pengetahuan, teknologi, dan kesehatan kedokteran spesialis THTKN yang bereputasi internasional melalui penelitian terutama yang berorientasi komunitas. Di samping itu, kami juga melaksanakan pengabdian masyarakat di bidang kesehatan kedokteran THTKL yang sesuai dengan kebutuhan masyarakat, baik taraf nasional maupun internasional. Selanjutnya, kami juga meningkatkan kerjasama dengan berbagai institusi nasional dan internasional dalam rangka pelaksanaan Tridharma perguruan tinggi. Kami juga menyelenggarakan pengelolaan program studi IKTHTKL yang berkualitas sesuai dengan standar Rinstra.
Kegiatan residen THTKL FKUNS meliputi kegiatan akademik dan pelayanan di Rumah Sakit Dr. Moewardi. Di antaranya laporan jaga setiap pagi, kemudian visita besar dan laporan operasi, dan juga kegiatan ilmiah yang meliputi journal reading, case presentation, referat, dan karya akhir. Kemudian juga melakukan kegiatan pelayanan di poliklinik dan operasi. Di THTKL FKUNS kami memiliki fasilitas penunjang untuk menegakkan diagnosis berbagai penyakit seperti nasoendoskopi, fiber optic laryngoskopi, esofagoskopi rigid, bronkoskopi rigid, audiometri, timpanometri, dan juga otomikroskopi. Kami juga memiliki fasilitas yang mendukung visi kami yang berorientasi THT komunitas seperti OAE, BERA, ASSR, untuk deteksi dini gangguan dengar pada bayi dan anak. Dan tidak sampai di situ saja, kami juga sudah mulai melakukan implan kohlea pada kasus tuli kongenital pada anak.
Saat ini, bidang THTKL FKUNS memiliki jumlah staf pengajar di Rumah Sakit Umum Daerah Dr. Moewardi maupun di Rumah Sakit Umum Daerah Jejaring di Boyolali, Wonogiri, dan Sragen.
Semakin terang.
Yang terus-menerus kami usahakan adalah membangun lingkungan kerja dan belajar yang baik, yang mendukung pertumbuhan keilmuan kedokteran spesialis THTKL FKUNS.
Okay, now it's time for Dr. Hadi Sudraja, Otorhinolaryngology consultant, to welcome the audience. So, Dr. Hadi, please, the time is yours.
Thank you, Dr. Rita. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Professor Salina Husain. I hope you are keeping well today, Prof. And good afternoon, Dr. Paramasari Dirgayu, PhD, as Vice Dean Faculty of Medicine. I hope you are fine too, Dr. Rosari. And good afternoon, all staff and all participants joining this international quiz lecture program. Thank you to every one of you for being here with us today. And Alhamdulillah, we are all still kept healthy by Allah Subhanahu wa Ta'ala. And with this message too, we can hear here. As we know, COVID-19 affects many aspects of life, and COVID-19 also makes people familiar with medical terms such as anosmia, hyposmia, parosmia, and so on. And this makes us as clinicians have to be ready to be asked by our patients, and we must explain clearly about this smell disorder. So, in order to understand better about smell disorder, now we have Professor Salina Husain, an expert in rhinology from Universiti Kebangsaan Malaysia. Professor Salina will explain deeper about smell disorder. It is an honor for us here to have a lecture from her. Thank you, Prof, for joining with us. And I hope we all can get benefit from this lecture so that we can give a better service to our patients. And the last, on behalf of the committee, I to welcome you all to International Program facilitated by World Class University Program of Sebelas University. Thank you, Dr. Sari. And now, please, I would like you to officially open this lecture. Thank you and wabarakatuh.
Okay, thank you, Doctor. Next, please, Dr. Paramasari, PhD, the Vice Dean of Faculty of Medicine, Sebelas Maret University, to deliver opening speech. Please, Doctor, the time is yours.
Okay, thank you very much for time, the ceremony. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Professor Salina Husain, our guest lecturer today from Universiti Kebangsaan Malaysia. Actually, we can say it in Bahasa, right? Yeah. And Dr. Hadi, the head of Otorhinolaryngology, head and neck surgery, specialized doctor, study program, Faculty of Medicine, Sebelas Maret University. The moderator, Dr. Dewi, and all the college will have spent time to attend and participate joining this event. First of all, I'd like to say sorry because our dean, Professor Refiono, has another things to do, so he couldn't attend personally in this important meeting, but he delivered a sincere regard for all of you, especially for Professor Salina. We appreciate to all the ENT department member. We honor here to having Professor Salina to give a lecture on smell disorder. Yeah, this topic is very important and kind of a hot topic. Thank you very much for Professor Salina Husain for spending your time and share your knowledge and also your experience to us today. And on behalf of Sebelas Maret University Faculty of Medicine, I really appreciate all of your effort. Hopefully, this lecture program gave us beneficial for all of us, and today's lecture will be fun and full learning. We also hope it can be vice versa next time. Maybe our lecture, also our staff will have a chance to share experience Indonesian cases in ENT also at Professor Salina's place. Well, in this great event, allow me to officially open this international guest lecture as one of world-class university program of Sebelas Maret University. Bismillahirrahmanirrahim. So this guest lecture will be open. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Paramasari.
Yeah.
Okay, before we begin, we will have some photo session together. Please open your camera and I will count to take the pictures. Pardon me, Dr. Paramasari and Professor Dr. Salina.
Yeah.
Please open your camera. Okay. Okay, we will take the picture.
All right.
Okay.
How are you, Professor Dr. Salina
you,
Husain?
Okay, I will count.
I'm fine. I'm okay. Thank you very much for inviting us.
Okay,
thank you very much for coming in our Zoom meeting. Yeah.
Yeah, thank you very much.
Okay. Okay, we will start to take the picture.
Okay.
1, 2, 3.
Yeah, this taking a picture is very important. Yeah.
Yeah, we can memorize this event.
Yeah. Okay. Everybody have a
I think
smile.
the last one. 1, 2, 3.
But you have a masker.
Unfortunately, we have mask here.
Yeah, unfortunately.
Okay. Okay, thank you for all the audience. I will continue. Next, I would like to remind all participants to keep following this international lecture until the end. And don't forget to fill in the attendance list from Google Form, which is linked in the chat room.
Yeah. But unfortunately, very sorry, I couldn't attend this meeting, the whole length of meeting. So please have fun. And I'd like to ask permission, Professor Dr. Salina, next time please come to Sebelas Maret University, Solo, the spirit of Java.
Yeah, thank you very much.
Yeah,
thank you
very much for all of you.
Yeah.
Wassalamualaikum warahmatullahi wabarakatuh. Ya, izin live.
Waalaikumsalam warahmatullahi wabarakatuh. Okay. Now it is time for a scientific session that will be hosted by Dr. Dewi Pratiwi, Otorhinolaryngologist consultant. Please allow me to hand over next session to Dr. Dewi Pratiwi as moderator. But just before we start, allow me to inform you briefly about our moderator. Dewi Pratiwi, Otorhinolaryngologist consultant, is a lecturer of Sebelas Maret University and the consultant of Dr. Moewardi Hospital, majoring in otology and ENT community. She is an active member on ENT Society. She's also a speaker in various national as well as international seminars and workshops. Now, please, Doctor, the time is yours.
Thank you, Dr. Dita. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. The Honorable Professor Dr. Salina Husain and the Honorable all participants of this lecture. I am Dr. Dewi Pratiwi, the moderator of today's lecture. I'm very pleased to see that many participants have joined this lecture. And for your information, this guest lecture is followed by ENT specialists, residents, and young doctor, not only from Solo, but also from Yogyakarta and Semarang. Welcome all of you to this lecture. Today's lecture is about smell disorder, what is new? Our speaker today is Professor Salina. Allow me to read you a brief CV of our speaker today. Professor Dr. Salina Husain is the senior consultant and head of Department of Otorhinolaryngology, Head and Neck Surgery, Faculty of Medicine, Universiti Kebangsaan Malaysia. She did the subspecialty training in rhinology in the University College London, UK. She was a visiting surgeon to Smell and Taste Center, Carl Gustav University, Germany, and many more of her professional experiences. She has published more than 80 articles in Scopus Journal. Her interests are in rhinology, allergy, septorhinoplasty, anterior scalp base, and smell and taste. Before the presentation begins, let me inform how the session. Professor Salina will be invited to present the material. After that, there will be panelization and followed by question and answer session. In Q&A session, all participants, if you have any question, you can raise hand or type in the chat room. Please do not hesitate to ask either in Bahasa or in English. For your information too, Prof. Salina can speak Melayu, so hopefully there will be no language barrier and we can get more knowledge from this lecture. Without further delay, now allow me to welcome our speaker, Professor Salina, to deliver her presentation. Prof. Salina, the time is yours.
Thank you very much, Dr. Dewi, for your kindly presentation. I will share the screen. Can you see this? My presentation on the screen?
Yes.
Yeah, okay, thank you very much.
Excuse me, Prof. Salina, we cannot hear your voice.
Sorry, Dr. Dewi.
Sorry, Prof.
Yeah, you cannot hear.
Can see the. Yes, we can hear now.
Can hear?
Now we can hear.
Can hear? If
no, we can hear.
Is on smell and taste disorders. What is new? Does smell important? Yes, it does. It is a very important sense because it has a clear effect on safety and quality of life. However, the smell is often neglected sense. Smell help us to avoid emergency situation like smoke, gas leaking in the kitchen, fire. Smell also help us to avoid consuming spoiled food like rotten egg, sour milk. Patient who has loss of smell, they have no self-control of body odors, so they will feel alone with this loss. Smell loss does affect quality of life, and smell does influence and alter our moods. Patient with smell loss may lead to depression. This is the anatomy of olfactory system. This schematic diagram shows the nasal cavity. This is the inferior turbinate, this is the middle turbinate, and this is the superior turbinate. And this is the olfactory cleft on the right and olfactory cleft on the left. And this is right olfactory bulb, and this is the left olfactory bulb. The olfactory epithelium and olfactory receptors situated in the olfactory cleft in the nasal cavity. Olfactory epithelium and olfactory receptors are located in the olfactory cleft in the nasal cavity. Therefore, smells originates from the nasal cavity. The olfactory bulb is housed in the skull base, above the cribriform plate and below the frontal lobe. Olfactory tract lies in the olfactory sulcus and ends in the olfactory cortex in the limbic system. There are more than 100 million of olfactory receptors in the olfactory epithelium, and these receptors, they are continuously degenerating. Chemicals must be dissolved in the olfactory epithelium mucosa in order for it to be detected by the olfactory receptors. Then the olfactory receptors will send the signal to the olfactory bulb through the olfactory neuron. And from there, the signal will be sent to the orbitofrontal cortex and limbic system via the olfactory tract. Smell, taste, together with trigeminal nerve, they are referred as chemosensory system. This is because they detect the chemical and send the signal to the brain. Smell is detected by the olfactory receptor. Different types of taste are detected by different regions of the tongue. For example, bitter is detected at the posterior one-third of the tongue. Sour is detected at the lateral border of the tongue. Sweet is detected at the anterior one-third of the tongue. And salty is detected at the anterior border of the tongue. The function of trigeminal nerve is to detect temperature, like cold, hot, or spicy food, and it also detect pain, touch, irritation, and lacrimation. The three chemical senses, like taste, olfaction, and touch, they influence each other mutually in the central nervous system. The smell can be detected orthonasally through the nose, and it can also be detected retronasally through the mouth, goes to nasopharynx, and then goes to the posterior part of the nasal cavity. For example, if we eat cold strawberry, so the smell of the strawberry is detected orthonasally through the nose. And when we eat the strawberry, the sweetness of the strawberry is detected by the tongue. And when we chew and swallow the strawberry, the production of the flavor of the strawberry is detected retronasally through the mouth, goes to the nasopharynx and posterior part of the nasal cavity. And the coolness of the strawberry is detected by the trigeminal nerve. Olfactory disorders can be divided into quantitative disorder or qualitative disorder. Under quantitative disorder, there are hyposmia, decreased olfactory function, anosmia, olfactory loss, hyperosmia or increased olfactory performance, and specific anosmia. Under qualitative disorder, there are parosmia, triggered distorted odor perception, and phantosmia, olfactory hallucination. What is the prevalence of olfactory disorder? Studies showed that 5% of population had anosmia and 15% suffered from hyposmia. Before I discussing further, I would like you to watch this interesting video on patient with a loss of smell. Loss of smell. And for people who can't detect odor, it can be one of life's greatest pleasures. It can also be dangerous, even life-threatening. Flowers, the inviting aroma of homemade soup and the comforting smell of home. They're familiar for most. But what if you could never smell them at all? Like I was missing something that everybody else had. Diana Prati was born without the sense of smell. She says that she realized something wasn't right when she saw others enjoy the flowers. I tried, to go up to that and I put my nose in and thought to myself, like, what are they talking about? Like, I don't get it. And it could be dangerous too. A cigarette Kaplani threw out of the car window, blew into her back seat, and started a fire. She smelled nothing. I was unaware. Drivers had to flag her down to get her attention. Leah Holzell lost her sense of smell suddenly after a viral infection, and she was devastated. The loss is momentous. Yes, loss of smell affect quality of life, and patient may have depression. There are several causes of olfactory disorders, which include sinonasal inflammatory diseases, post-upper respiratory tract infections, head trauma, congenital, neoplasia, toxins, and neurodegenerative diseases. The causes of olfactory disorder can also be divided based on the location, like in the nasal cavity or in the olfactory epithelium or central nervous system. Loss of smell can be also due to malingering and hysteria. The most common cause of olfactory disorders is sinonasal inflammatory diseases. It accounts about 36%. It is mainly due to mucosal edema leading to obstruction of the olfactory cleft. For example, in patients with allergic rhinitis, non-allergic rhinitis, rhinosinusitis with or without nasal polyposis, and atrophic rhinitis. The second etiology of olfactory disorders is post-upper respiratory tract infection, about 21%. It is mainly due to viral infection. Majority of patients had a good recovery of smell function. However, few of them had permanent smell loss and few of them had parosmia. 18% is due to head trauma. The olfactory fibers are damaged due to rapid acceleration and deceleration of the brain during head trauma. It has a poor recovery rate. This MRI to show you the olfactory bulb in normal healthy patient. However, in patient with post-infection or post-trauma, the olfactory bulb may be atrophic or olfactory bulb may be distorted. This causes permanent loss of smell. 4% is due to congenital, like Coleman syndrome, Charge syndrome, and it is due to aplasia of olfactory bulb or sulcus. And this MRI to show you the absence of olfactory bulb and olfactory tract in patients with Coleman and Charge syndrome. 4% is due to neoplasm. It can be olfactory neuroblastoma, meningioma, frontal lobe gliomas, or respiratory epithelial adenomatoid hamartoma, or RIA. Olfactory neuroblastoma is a malignant tumor arising from the olfactory bulb. Patient presents to you with anosmia, epistaxis, and nasal obstruction. So this is a combined surgery with neurosurgeon. The neurosurgeon will remove the tumor in the brain together with olfactory bulb because this tumor arising from the olfactory bulb. So the yellow color structure here is the olfactory bulb. When the tumor is removed, so we can see the frontal lobe, the inferior surface of the frontal lobe. So in this patient, she will have a permanent anosmia. Olfactory groove meningioma arising from the meninges or dura of the brain. It causes compression effect on the olfactory bulb and olfactory tract. Therefore, total removal of the tumor will improve the olfactory function. The last one is a case of respiratory epithelial adenomatoid hamartoma. It is a tumor arising from the olfactory cleft, and it causes obstruction to the olfactory epithelium and olfactory receptors. Once the tumor is removed, patient will regain the smell function. Toxin accounts for 4% of causes. It is due to environmental pollutants or metal fumes. It can be due to industrial plants like formaldehyde, and toluene and paint solvent is one of the cause of the smell loss. This chemical causes acute or chronic damage to the olfactory epithelium. The last one is the neurodegenerative disorders. Olfactory impairment may be the first clinical sign in patients with neurodegenerative diseases. They may have olfactory loss 3 to 5 years earlier before they start to have motor symptoms in Parkinson's disease and dementia in Alzheimer's disease. How do we manage patients with olfactory loss? First of all, we have to take a proper history taking and do physical examination. This is a routine endoscopic examination that we perform in the clinic. We will look on the floor of the nasal cavity and in the nasopharynx to see any mass or any mucopus. And after that, we examine the upper part of the nasal cavity, including the osteomeatal complex, to see any mass. This patient has polyp grade 1. And then we examine the olfactory cleft to see any mass or any obstruction in the olfactory cleft. Do we really need to test olfactory function? Why not we just ask the patient whether they have normal smell or they have loss of smell? And can we measure the olfactory impairment? I will discuss this in my next few slides. Study by Deans et al. On 750 patients. About 20% of them complain of loss of smell, and about 60% complain of loss of smell and taste. But when they did the smell test, they found that about 70% of patients had smell loss. It's about 3 times more, and only about 2.5% had loss of smell and loss of taste. Therefore, smell testing is very important. We have to do smell testing in order to verify the validity of the patient's complaint and to detect malingering and to obtain the objective assessment for determining compensation for disability. There are 2 types of olfactory testing. The first one is psychophysical test, and the second one is electrophysiological test. The psychophysical test is semi-objective test because it depends on patient's compliance. This test is a relatively low-cost test with a short examination. The second test is an electrophysiological test. It is an objective test because it does not depend on patient's compliance. It is a highly reliable test. However, it is a time-consuming procedure. Psychophysical olfactory tests that are used worldwide and has been validated in many countries are sniffing stick smell test. This test was developed by Hamel in Germany, and the second one is UPSIC. It was developed by Doty in America, and we have diskette smell test and olfactometer. Among these 4 tests, only sniffing stick smell test has 3 tests in one. For the electrophysiological test, the commonly used are electroencephalogram or EEG and electroolfactogram or EOG. In UKM, we use sniffing stick smell test. Number 1 is identification test. It is commonly used in the clinic. It is very easy to perform and it takes only 5 to 10 minutes. The test kit can be repeatedly used for 1 year or till the odorous vapor fades off. The other 2 is discrimination test and threshold test are mainly used in research or we want to do further investigation in the clinic. The smell test was developed by Hamel in Germany. Therefore, majority of odors tested are not familiar to population in our region. Studies showed that smell performance depends on the cultural backgrounds. We have conducted and published a cultural adaptation study where we change non-familiar odors to familiar odors. This is very important to avoid misinterpretation of results leading to a wrong diagnosis. For example, we change blackberry to durians, we change chive to kunyit, and we change licorice to jintan manis, and we change rum to buah mangga, and we change ham to langsat, and so on. And this is the final version of chart of Malaysian version of sniffing stick smell test. This video shows you how we perform the sniffing stick smell test. This is the smell test. The discrimination test has 3 pens, and 2 pens has the same odor, and the other pen is different. So patient has to choose a different odor pen, and patient has to close the eye. Olfactory impairment can be measured. The cut-off point of smell identification test score for hyposmia is different from Malaysian population and European population. The cut-off point for hyposmia is less than 6 for children, less than 9 for adolescents, and less than 11 for adults. And the cut-off point for TDI score, that is the total score of threshold, discrimination, and identification tests. The cut-off point of TDI scores for hyposmia are different in different age group, and it differs from Malaysian population compared to European population. However, there is no significant difference in detecting the lowest concentration of odor between men and women. We conducted a study to look into the brainwave response towards odorous and non-odorous olfactory stimuli. A total of 44 healthy volunteers who passed smell identification tests were recruited in the study. Odorous olfactory stimuli used in this test was lavender essential oil, and non-odorous stimuli was normosaline as a control. EEG was recorded from 19 electrodes on the scalp. We found that there was a significant reduction of beta and gamma wave in patients who received normosaline or non-odorous stimuli compared to patients who received lavender or odorous stimuli with a P less than 0.05. Based on this pilot study, we are in the progress of doing research to look into the brainwave response in patients who has normal smell compared to patients who anosmia. If the results show a significant difference between these two groups, we will do further research to look into the possibility of its usage in the clinical setting. Brain waves is very sensitive and useful in detecting malingering. It is also can be used to determine whether patient able to get the compensation for the olfactory disability. How do we want to treat patient with olfactory loss? The treatment of olfactory impairment depends on the underlying causes. Allergic rhinitis and rhinosinusitis are treated with intranasal and systemic corticosteroid with antihistamines and normal saline irrigation. Patients who have acute bacterial rhinosinusitis should be treated with antibiotics. Surgery is the mainstay of treatment in majority of sinonasal tumors. Studies show that 45 to 56% of patients who had post-upper respiratory tract infection had improvement in their smell function, partially or total, and between 5 to 15% of patients who had head trauma showed improvement, partial or total improvement in their smell function. Many studies advocated medical treatment like vitamin A, vitamin E, zinc, and so on. However, the result was not promising. Smell training using essential oil like rose, lemon, eucalyptus, and clove for 5 to 10 minutes twice daily for 6 months showed an improvement in olfactory function. Hamel et al. In 2009 conducted a study on patients who had smell loss. They found that about a quarter of patients who had smell training showed significant improvement with P less than 0.001 compared to patients who did not do smell training. I will touch a little bit about the gustatory testing. So ageusia is total loss of taste function of the tongue. Hypogeusia is a reduced ability to taste substances, and dysgeusia is a distorted sense of taste. We use strips that containing sweet, sour, bitter, and salty taste to test their taste function. Since we are in the pandemic COVID-19 era, so I will talk a little bit about olfaction and COVID-19. Severe acute respiratory syndrome coronavirus type 2, known as COVID-19, became a global health pandemic since March 2020. And the common symptoms are fever, sore throat, myalgia, and difficulty in breathing. The Center of Disease Control and Prevention in the United States include the loss of smell and taste as a valid symptom of COVID-19. There have been many postulations of mechanism of olfactory impairment. It is basically due to the invasion of the virus into the olfactory bulb and olfactory neurons, and also olfactory receptors. And it is due to inflammation of the nasal mucosa leading to obstruction of the olfactory cleft. We conducted few studies on patients with COVID-19. The symptoms were assessed subjectively using validated Malaysian Smell and Taste Questionnaire, or MSTQ, and the smell was assessed objectively using culturally adapted Malaysian version of sniffing stick identification test. This is video to show you we did the test on patients with COVID-19. The first study involved 81 patients with positive PCR COVID-19 tests, and all these patients, they did not complain of smell impairment. What we found in our study, 23% of patients had normal smell. However, 77% who did not complain of olfactory impairment had olfactory impairment. And out of these, 51% had hyposmia and 14% had anosmia. So this is proof that smell test is important and has to be done in all patients with COVID-19. In the second study, we recruited 82 patients with or without any complaint of loss of smell, and they had a positive PCR COVID-19 test. We did the smell identification test, and 18 of patients had normosmia, 61% of patients had hyposmia, and 21% anosmia. We found that there is no significant correlation between olfactory impairment and RNA viral load, with R negative 0.54 and P equal to 0.61. Hoffman stated that smell loss may be due to the pathogenesis involving the olfactory neurons, and the viral load samples were taken from the nasopharyngeal and oropharyngeal swab may not be a representation of viral loads within the nasal cavity. This may explain why there is no statistical correlation between olfactory impairment and RNA viral load. This picture just to show you that the viral load sample was taken from the nasopharynx and oropharynx. It is quite far from the olfactory cleft where the olfactory receptors is. A meta-analysis by Agyeman et al. In 2020 discovered that higher prevalence of COVID-19 when smell impairment was assessed objectively. Like in our study, all patients did not complain of smell loss. However, when we did a smell test, about 77% patients had smell impairment. Therefore, the assessment and evaluation of olfactory function is crucial in patients with COVID-19. Although there is no correlation between smell loss and viral loads of nasopharyngeal and oropharyngeal swab, subclinical smell loss may be the only symptom of COVID-19 unrecognized by patients. I would like to conclude that smell is an important warning system, and to obtain the smell test cultural adaptation and cut-off point for hyposmia in different populations are crucial to avoid wrong result and wrong diagnosis. Asymptomatic COVID-19 patients did not complain of smell impairment. However, majority of them were proved to have olfactory loss on smell tests. Before I end my presentation, I would like to show this video of patient who had COVID-19 and anosmia.
I am COVID positive, and he told me to try and eat like some nasty stuff, but I don't have any stuff right now. So I figured I'd just like stuff that would be strong. Just to see what it's like. So here's an onion.
patient basically cannot smell, cannot taste, and cannot feel the hot and spicy of the food, and cannot feel the irritation of the food, and cannot feel the pain on consuming pungent food. So he is basically has loss of smell, loss of taste, and also absence of trigeminal nerve innervation. With that, I would like to acknowledge all my doctors, my staff, who helped me a lot in my research and in the management of patients in the clinic and ward. We organized a workshop on smell and taste in 2019, and we invited the international guest speaker, Professor Dr. Thomas Hamel. He's the one who invented the sniffing stick smell test. So we plan to do this test every year. However, because of pandemic COVID, we have to stop for a while. So we will continue doing the smell and taste workshop in future. Who are interested to join my workshop, you can freely email me and I will give a brochure of the workshop. And in UKM as well, we offer a fellowship in rhinology, allergy, and smell and taste. Who are interested to be my fellow, you can email me and I will give you details on this. This is my reference. With that, I thank all of you for your kind attention. Thank you very much.
Thank you very much, Professor Dr. Salina, for the very interesting and informative lecture. Now we come to the panelist session. We have two panelists today. Dr. Hendra Dewi, ENT specialist from Rhinology Division, and also Dr. Niken Diah Aryani from Allergy Division. Dr. Dewi and Dr. Niken, you can join in this session. Okay, so for the first panelist, Dr. Niken, please, if you have any comment or question to Prof. Salina, please, Dr. Niken. Dr. Niken, sorry, please unmute the, okay. Dr. Niken?
Okay, thank you for Dr. Dewi Pratiwi as a moderator. And good afternoon, Prof. Salina and all of the audience. I am Niken Diah Aryani, otolaryngologist from Allergic Immunology Division. Today, I would like to ask Prof. Salina about is the smell test still being done during COVID-19, Prof, in UKM?
Yeah, thank you very much, Dr. Niken, for the question. Basically, in UKM, we don't do smell test for all COVID patients. We do only for research because the smell test is quite expensive. And then one kit of smell identification smell test is about around 2,000 ringgit Malaysia. So if we only use this smell test for COVID-19 patients only, so we won't use its mix. Like it's not mixing with a normal patient and COVID-19 patient. So we have a separate test for normal patient and for patient with COVID-19.
Okay, thank you, Prof.
But in the clinic, but in the clinic, we are not testing all patients with this kit. Because if patient has loss of smell or patient has like hyposmia, then we do the test. because we are worried this patient has COVID-19, right? So we want to confirm that whether how is the function of smell.
Okay, thank you, Prof. Salina. And then second question, Prof. I saw in your presentation, after smell treatment, after 6 months, what can we do to evaluate after patient smell treatment after 6 months?
Thank you. So like if patient have anosmia in my clinic, if patient have anosmia, so I start the patient with a smell training, because myself, I haven't done research on patient with anosmia and smell training, because this one is based on the European study. They show that there is some improvement. So for me, if a patient come to the clinic and I give the patient the smell training, how I'm going to know that patient has improvement? I use the sniffing stick smell test to test whether the score is become more or become low. So that's why we have a scoring system for the hyposmia and anosmia.
Okay, thank you, Prof. Salina. Your presentation is very interesting for us. Maybe someday, if Prof. Salina have a workshop again with smell test, I want to join.
Yeah, thank you very much.
Thank you,
Prof.
Dr. Dewi
Still
Pratiwi.
not finished to explain. You can finish the explanation, Prof.
Okay, the other one, if after the smell training, if like patient has no improvement, I think nothing much we can do, because worldwide study, they started treatment that like medical treatment using vitamin E, zinc, and all that. It did not show any promising effect.
Sorry, Prof. We cannot hear your voice, Prof.
I think my connection.
We already hear.
Yeah. So because so many causes of loss of smell, we have to do the investigation first. If let's say none of the investigation showed that it's because of the list of causes that I showed in the presentation, then I think nothing much we can do after 6 months if there is no improvement of smell. But now in Europe, they still use vitamin E drops. They still giving that medical treatment to patient. Vitamin E drop, I think 100,000 international unit BD. It's not 100, it's about 10,000 international unit twice daily. But that medication is not available in Malaysia.
Okay, Professor Salina. I think it's, the presentation is very interesting. Thank you very much. Give us a lot of new one for knowledge, and then maybe share about sniffing stick in our division in Moewardi hospitals have sniffing sticks too, but now we have stop it because of pandemic. So maybe if the pandemic is going over, we can do sniffing sticks again, and then skin prick test. Thank you, Prof. Salina. Maybe Dr. Dewi, Sendra Dewi, please.
Okay, thank you, Dr. Niken. Thank you, Professor Salina. Because Dr. Dewi is still in the meeting, we will continue into the Q&A session first. Before I
I see that there is some question in the chat room, but before I read them, if any participant want to join online and ask directly to Prof. Salina, please you can raise hand. We have Dr. Aziza here, and I give the first opportunity to Dr. Aziza to give a question to Prof. Salina. Thank you for the opportunity. Good afternoon, Prof. Salina. Can you hear my voice clearly?
Hello, good afternoon.
Oh, yes. Yes. Okay, we can hear your voice.
Okay, good afternoon, Prof. Salina. Glad to see you here. I am Aziza. Allow me to ask some questions. First question, aside from smell disorder, COVID-19 patient also experience loss of taste. So how to treat a patient with loss of taste after being affected by COVID-19? And for the second question, what about giving zinc or vitamin D to patient with smell disorder? Thank you, Prof.
I cannot hear the second one. The second question.
Okay, for the second question, what about giving zinc and vitamin D to treat patient with smell disorder?
Because the voice is double. The voice become double. So
voice is double.
Feedback. Okay. So you can hear the question, Prof?
Number
I will
one,
repeat it for you.
Okay, can.
Okay. Number 2 is how about giving zinc and vitamin D for patient with smell disorder?
Okay. So thank you very much, doctor. The first one is patient COVID-19 who has loss of smell and loss of taste, right? So because I don't do extensive study on COVID-19 patient who had a loss of taste. So we did a questionnaire study. We did a questionnaire study that we asked together the loss of smell and loss of taste. So most of patients, when they come, if they have loss of smell, they also have loss of taste. But loss of taste is much more lower than loss of smell. That means the majority of patients come with loss of smell, but some patients, they come with loss of smell and taste. Okay, after 2 weeks, once they regain all the smell function, they will also regain the taste function. Because they will get
Sorry,
both.
Prof, the connection is not good. We cannot hear who.
Can hear now? Can hear? Hello? Dewi?
Yes.
Dewi?
Okay, continue, Prof.
Dewi, so if patient have a loss of smell, majority patient has loss of smell, and some of them will have loss of taste. So once after 2 weeks, after the viral load become lesser, so they will regain the loss of smell and loss of taste together. So if they regain the loss of smell, usually they will regain also loss of taste. But basically, I didn't do the test to check whether is like a patient really regain the loss of taste, because I didn't check. The thing is because the taste strip that the taste strips that we bought from Germany is very expensive. So I can't do that in all patients. So for that I cannot tell in detail whether their their loss of taste is really regained based on the objective test. And the second question just now is okay, the treatment with vitamin D, right, doctor? The treatment with vitamin D. As far as I know, all this treatment with vitamin doesn't work really well. But I'm not sure because I didn't do study myself. So only vitamin E that might help patient. But that one is vitamin E drops. It's not vitamin E orally. Patient has to like take a vitamin E drop twice daily.
What about zinc, Prof?
Sorry?
What about giving zinc? Zinc for
Zinc?
the patient? Yes.
Yeah, the zinc also in Germany they give this treatment with zinc. But the thing is they have to monitor patient because they don't want patient to have like toxicity to zinc. So what they found is like about 20% only have improvement. So that's why they are not using that regularly in the clinic. They use in some patients, but not all patients.
Okay, thank you very much, Prof.
But me myself, I don't have any experience in patient using zinc or vitamin E or vitamin A. I don't have any experience, just based on the literature review.
Okay, thank you, Prof. Salina. Thank you for the question too, Dr. Aziza. So for the next questions is come from Dr. Anna from Semarang, Prof.
Yeah.
Okay, Dr. Anna, you can start to unmute. Oh, okay. So Dr. Anna is asked, do you read? Oh, okay. Dr. Anna, please.
Okay. Okay, thank you, Dr. Dewi, for the opportunity. Assalamualaikum, Prof. Salina.
Waalaikumsalam.
Yeah, greeting from Semarang, Prof.
Yeah.
Thank you for your wonderful presentation. It's a very excellent presentation about the olfactory dysfunction. Actually, I like to ask about your how do you perform the smell test? Are you regularly perform smell test for the CRS patient? And how about this situation in this pandemic situation? Did you still perform the olfactory test for all the patients or only for the research? Thank you, Prof.
Yeah, thank you, Anna. So basically now because of pandemic, we do smell test only for research purpose. That means there is ongoing research on prevalence of smell loss and taste loss in patients with CRS. So we are allowed to do the test only for research purpose. In the clinic, I'm not doing it because I don't want to waste my smell kit. Because now once you do to all patients in the clinic, it's like unluckily one patient have COVID, then I have to throw the smell test, the smell kit.
Okay, thank you, Prof, for your explanation. Thank you, Dr. Dewi.
Thank you, Dr. Anna. Thank you, Prof. So we still have the other participants who want to ask. Maybe Dr. Novi, have you joined us? Dr. Novi?
Yeah.
Okay, please, Dr. Novi.
Thank you, Dr. Dewi Pratiwi. Good afternoon, Prof. Asma, Prof. Salina.
Yeah, good afternoon, Dr. Novi.
Yeah. I would ask for you which one is the best preparation nasal saline drops or nasal saline spray or nasal saline irrigation for patients with smell disorder in COVID-19?
This is Prof. Salina, Dr. Novi.
Yeah. So the question is for the patient with COVID-19, what is the best, right?
Yeah.
Either nasal saline spray or nasal
spray,
saline,
drops, spray or drops.
Nasal saline spray, and then or
drops.
Nasal
saline drops or nasal saline irrigation, bro.
Nasal saline irrigation. And the other one is the other two, is it? The other okay. So my answer is because in my center, if patient has COVID-19 and patient has symptoms, right? So usually the symptom will disappear after 2 weeks. Majority of patient, they will have a symptom of COVID-19, and majority of patient, the symptom disappear after 2 weeks. And some of them can have the symptom up to 1 month. So in my center, I don't give any medication for the nose. So even the corticosteroid spray I won't give, because and then all this nasal saline irrigation, nasal saline spray also I don't give, because this one is upper respiratory tract tract. They part of the aerosol generated procedure. Then if we put the spray, it can spread around. That's why I don't give any treatment for patient who has this nasal symptom if the patient has COVID-19. But I'm not sure. This one depends on center. I'm not sure. Some center they will treat the patient with some sort of like nasal spray or nasal irrigation. This one is not wrong or it's not right. So actually depend on us whether we want to what we want to use to treat the patient.
Okay. Thank you.
Yeah, thank you, Dewi.
Thank you, Dr. Novi. So, Prof. Salina, even for nasal saline irrigation, you didn't give it to COVID-19 patients?
No. I didn't give. Because when I see the patient, I just wait for because medical people, they will give a supportive treatment, right? They will give a claritine. They will give if patient have they will give some supportive treatment. Patient have fever, they will give paracetamol, like like analgesia and all that. So this thing will settle within 2 weeks. So once patient that's why I don't give. So actually, when I give lecture to all general practitioner and private ENT surgeons, so I just inform them, because based on IAKI guideline, they don't recommend to give nasal spray, right? Because it will spread the droplets and all that in the environment. That's why they try to avoid using all this spray in patients with COVID-19. Maybe irrigation is okay, because irrigation is just like patient itself, and then it won't spread into the environment. I'm not sure. So there is nothing right or nothing wrong. But I think it is up to us how we want to treat the patient.
Okay, Prof. So, when the reasonable time for us to give an instruction to the patient to do smell training for COVID-19 patients? Okay,
if patient has COVID-19, and then I will give the smell training to patient who have anosmia only. If hyposmia, usually patient will get the smell function, but for anosmia, I will give the smell training. So we can give the smell training after patients repeated PCR. Once the PCR negative, so they can be on the smell training.
Maybe you can share. Okay.
Sorry, because usually the patient who has like COVID-19, the infectivity rate is within 2 weeks, right? So after 2 weeks, they will repeat the PCR. If the PCR negative, then patient can come normally in the clinic, and then we can do endoscopy examination, and we can give we can offer the smell training.
In UKM, Prof, maybe you can share the smell training, the procedure of smell training. Is it with 4 types of odor, or how many odor you use to give to the patient to instruct them to inhale the odor, the odorants, I mean?
Yeah. Yeah, so it's basically in UKM we bought this kit, the smell training kit that contain all these 4 essential oil. It contains one bottle is 4 bottles. One is a rose, one is lavender, and the third one is eucalyptus, and the 4th one is clove. So actually we bought this from Germany. So we give we that for 6 months, but I've never done a thorough study on this. How does this smell training affect the patient with COVID-19? Whether the patient regain smell, how many %, or it doesn't work at all. So I don't have any experience on this.
Okay, thank you very much, Prof. I see that there is participants who raise hand. Dr. Astrid, this is our resident. You can start to unmute, Dr. Astrid.
Thank you, Doctor. Assalamualaikum, Prof. Salina.
Waalaikumsalam, Dr. Astrid.
Thank you, Prof. I am Astrid. I am the resident of Otorhinolaryngology Head and Neck Surgery, Universitas Sebelas Maret. I want to ask a question, Professor. How is smell training therapy can be effective for a patient with smells disorder, Professor? Thank you, Professor.
Yeah, thank you very much. The smell training, actually our smell has a memory, because when we smell, we have there's a memory in our brain, in orbitofrontal cortex. So if like when we watch like a series like a film, like, so if they ask the child to smell something that they smell when they were small. So or sometimes we saw a series that when somebody eat something that was cooked by grandmother like 20 years ago, when they start to eat this food, they start to remember, oh, this food is almost like my grandmother cooked 20 years ago. Because our brain has a memory for smell. There's a specific memory for smell. So that's why they believe that if we use smell training, because there's a memory in our brain, so we give this odorous like this for this. Actually, you can choose any order that you can give, as long as that order has a high smell, or the odor is very strong, like clove, right? The odor is very strong, so it might awake your memory. And with that, they believe that patient can have some sort of improvement of smell.
Okay, thank you, Professor. It recall the memory. Yes, Professor.
Yeah. Yes. Thank you very much.
Thank you, Professor.
Yeah.
Thank you, Dr. Astrid. And there's Dr. Rofi too, who raised hand. Dr. Rofi can unmute.
Assalamualaikum warahmatullahi wabarakatuh, Prof. Salina.
Yeah, Waalaikumsalam.
Pardon me, Professor. I'm Rofi. I am the resident of Otorhinolaryngology Head and Neck Surgery of Sebelas Maret University. I would like to ask a question about how long it takes for the recovery of olfactory function in patient COVID-19 with anosmia. Thank you, Professor.
Yeah, thank you very much for the question. Basically, the smell training is 6 months. So if you give the smell training, either to patient who had history of like URTI, then patient develop anosmia, or patient with COVID-19 develop anosmia. So the duration of treatment is 6 months. If after 6 months there's no improvement of smell, I think nothing much we can do.
Okay, thank you, Professor.
Yeah, thank you.
Thank you, Dr. Rofi. So, Prof, after 6 months, if there is no improvement, the smell training is stopped or they need to continue?
Some patients, they just want to continue, but it depends on patient. If patient want to continue for 1 year, it is up to them. But the study show is up to 6 months. Like some patient, after 6 months, if no improvement, they will stop. They don't want to continue anymore because they don't see any improvement, and the smell training is quite expensive. The essential oil is quite expensive. Even one, if we buy through online, right? Even one is cost about like 250 ringgit Malaysia. If you buy 4, it costs about 1,000 ringgit to 1,500 ringgit. So some patients they cannot afford. So because of that, there are many factors that why patients don't want to continue with this smell training. But when we tell the patient, when we want to start the treatment, then we say that actually the duration is 6 months.
Okay, thank you, Prof. And I think there are some questions in the chat room. Okay, I will read from the first question is from Kenneth. Sorry. Is there any situation that GP, general practitioners, should be aware of where smelling impairment is a red flag of an impending emergency? How should a GP handle those cases?
Okay, thank you for the question. So honestly, that I just want to tell that in Malaysia, the smell and taste is not like as advanced at like we also at the starting. It's not as advanced in Germany. So the smell and taste is like in our country is about, it just started when I came back from Germany. So most of GP, they are not using this smell smell test. They are not used to this. So now we started to educate GP and all that. They can use this smell test in their clinic if they are worried about the COVID-19. At least that they have a warning system that oh, this patient might have a COVID-19, and they can for PCR. But the thing is, we are not using that in Malaysia yet. So all GPs are not using that. And the other one, because this is like a kit, right? So it can be used up to 1 year or till the odor fades off. This so it can be used like in so many patients. If patient has no COVID-19, that means you can use for 100 patient, 200 patient. But if once you get one patient with COVID-19, you cannot use it anymore. So there's another one that the smell kit is upseat, right? The booklet. So that booklet is quite expensive as well. So I think it's not like cost effective to be used in GP because both tests are expensive. But if a general practitioner, they want to do this, whether for protection or that, I think it's no harm to use this smell test in the clinic. Because the other one is because when patient come to our clinic, then we patient already vaccinated, and we check the temperature and all that, and we ask whether the patient has a history or not. And majority of patients, hopefully they don't have COVID-19, but don't know, right? or you are not sure, right? Patient walking to the clinic and then they might have a COVID-19 positive. So I think a smell test not they said that cost effective to be used now. So once the COVID-19 over, then you can use the smell test in your clinic.
Okay, so it is not safe for now because we still have the pandemic. The pandemic is not over yet. Okay, thank you, Prof. And the next questions come from residents from Semarang, from Diponegoro University. Is it possible, I will ask, is it possible olfactory dysfunction affect gustatory or otherwise gustatory dysfunction affect olfactory?
In COVID-19 patient or general?
In general.
In general. So whether can smell loss affect loss of taste, right? Or can loss of taste affect smell loss? That's the question, right?
Yes, Prof.
Okay. So if patient has loss of smell, it can be orthonasal. Right? It can be so if patient have loss of smell, not necessarily patient will have loss of taste. Loss of smell, if there is an anterior blockage of the nose, then patient will have loss of smell. If, for example, if patient have a polyp grade 3, so everything is blocked, right? So patient will have loss of smell, but patient won't have loss of taste. But if patient has like a tumor, if patient have a tumor, or let's say olfactory neuroblastoma, because the tumor arises from the olfactory bulb, and then patient will have loss of smell as well. And then when patient eat, patient will have a loss the loss of taste. There are two. Whether patient loss of taste to sweet bitter or sweet bitter sour or sweet bitter sour or salty, right? So the thing is the taste. What our tongue can feel is that these two, these four taste, right? But when we eat, like example, strawberry, the flavor of the food is smelled by the nose. So patient has, if patient has tumor, right? Patient has like patient can feel the bitter and all that, the bitter, the sour, the sweet, and the salty. But patient cannot smell it because of patient cannot smell it if patient have obstruction to the whole nasal cavity. If there is no obstruction at the posterior part of the nasal cavity, patient can smell of the flavor. It's not smell of the strawberry, it's smell of the flavor of the food. And then if patient has loss of taste, I think it doesn't affect loss of smell. If patient loss of taste, that means if patient lost this bitter, sweet, sour, and salty, it won't affect the loss of smell. And the other one is there's another sense that give a perfect food of strawberry or a perfect food of like a noodle, hot noodle soup. There's a trigeminal nerve innervation. If there is absence of trigeminal nerve, a perfect taste and a perfect smell of strawberry or a perfect smell of noodle soup won't be felt by patient. It won't be felt by the patient. So there are three. For when we eat something, need three senses should be intact: taste, smell, and trigeminal nerve.
Okay, Prof. In your slide, there is a retronasal airflow. That's why if we lost our smell, it can cause loss of taste too. But not all of smell disorder will have a loss of taste too. But if we have a lot, but if there is a patient with taste disorder, it won't cause smell disorder. Is it right, Prof?
Yeah, for me it's like that. Right? Taste won't affect the loss of smell, but loss of smell will affect the taste function. The taste will affect the loss of taste.
Thank you very much, Prof. And we still continue for the question in the chat room. There is Dr. Odi, the resident from Sebelas Maret. I would like to ask about using ethyl alcohol threshold test for olfactory assessment, especially in COVID-19 patient. What is your opinion or advice, Prof?
Okay, actually ethyl alcohol, is it, Dewi?
Yes, ethyl alcohol.
Ethyl alcohol. So ethyl alcohol, from my understanding, ethyl alcohol we use for threshold test. We use a threshold test to see the lowest concentration of smell that patient able to smell. So it goes back whether during this time if we can use or not in patient with COVID-19. So I think like all these smell tests, like we try to avoid doing like routinely in during this pandemic. So is that answer my question? Because I'm not sure why we use. Maybe somebody that asking the question. Are you using the ethyl alcohol routinely in patient to test for what? To test for odor or to test for the concentration?
I think because in this pandemic situation, so ethyl alcohol threshold test is used as a screening test for a patient with smell disorder in COVID-19 patients.
Yeah, because basically I think you want to test the threshold. What is the lowest concentration that the patient can smell? I think maybe because that one is part of the threshold test.
Okay. Okay, Prof. Thank you. And for the next, there is question from Dr. Tari, the resident. Is there any grading or level in olfactory disorder, and what instrument or scoring we can use to measure it?
Scoring this one to measure the smell, to measure the smell function, right?
Yeah, I think like a sniffing test.
Yeah,
we can use to measure.
Yeah, sniffing stick smell test can be used, but we have to use this test to measure the patient is this smell test like a sniffing stick and upseat or this cat smell test. These are semi-objective. So we can measure whether the patient has like the score is like 9, 10, or 6. We can measure that. But the thing is, this one is semi-objective. Patient can lie, right? If patient want to get for compensation, they will just say that I can't smell anything. Yeah? That one is semi-objective. That's why this one is like all these tests, they semi-objective tests. So we have another one is a brainwave. Brainwave is like currently is more used in research because they did so many studies on brainwave and their results are like contradicting each other. So they are not using this worldwide to be used in the clinic because of that. And then it is very long hour procedure. It takes maybe about 1.5 to 2 hours each patient. So that's why they are not using this. But in our center, we did the study for brainwave, and we have developed a software to make it easier to read the EEG recording. But this one is still under research. So this brainwave is objective test, is highly reliable, but the thing is a time consuming. So to answer that question, we can measure the smell impairment.
Thank you, Prof. I see that there is resident from Udayana University from Bali, Prof. Dr. Bulan. She asked about the treatment and the prognosis between hyposmia in COVID-19 patient and without COVID-19. Is there any difference?
The diagnosis, huh?
The treatment and the prognosis, Prof.
I think if normal URTI, upper respiratory infection, and COVID-19, they have a hyposmia or total loss of smell. The mechanism almost the same. Yeah, because sometimes in URTI, upper respiratory infection, some virus like, or maybe some virus like, I'm not sure, maybe para-influenza, something, that virus that a high virulent virus, they can invade, this virus can invade the olfactory neurons and go to olfactory bulb and causes these receptors degenerate. So because of that, the olfactory receptors cannot regenerate. So patient will have anosmia. And then like in COVID-19, is also a virus, that strong virus that may invade the neuron and olfactory bulb as well. So I think the mechanism is almost the same for any virus. So either they invade partially or they invade fully. If they invade partially, maybe patient have hyposmia, and the receptor cell will regenerate. So patient will gain the smell again later, maybe after 2 weeks or 1 month. But it's the same for COVID-19 as well, because it's a virus. So they can invade partially or totally.
Okay, Prof. Thank you, Prof. But why in COVID-19 patient with a smell disorder, some have it temporary, but some have it longer? Or maybe could it be permanent?
Yeah, okay, thank you. It's basically in COVID-19 patient, they have this temporary or permanent smell loss. Temporary is basically maybe due to when they have this like viral infection, right? So their mucosa of the nose swollen. That means all the mucosa become edematous. So maybe the mucosa at the olfactory cleft also edematous. So during this stage of during this stage, so a patient will have maybe anosmia or hyposmia. So once the mucosa edema settle, everything settle, the medication and all that, patient will regain the smell. However, if the virus invade the neuron or invade the olfactory bulb, then patient will have a permanent smell loss.
Okay. Yes, Prof. Thank you for the excellent explanation. And actually, Prof, I have a patient yesterday with autoimmune like lupus and Sjogren. She has lupus and Sjogren and reported loss of smell after she had COVID-19, but returns to normal within 2 weeks. But then a month after that, she reported that her smell is distorted for about 3 weeks until now. So if he smell the odorant is not, she cannot mention the exact odorant. It like a rubber or something about like that. So she still have smell function but distorted. Is it related to the COVID? Is it still related to COVID-19 or maybe caused by her autoimmune, Prof?
Okay, thank you very much, Dewi, for asking that question. Okay, there's another olfactory disorder in patient with COVID-19. They have parosmia, the one that like Dr. Dewi told us just now. The patient will have parosmia. Okay, in COVID-19, like when patient get this infection, patient will have hyposmia or anosmia. So hyposmia may be due to invasion of the virus, right, to the olfactory neuron or olfactory bulb, and both in hyposmia or anosmia. Okay, after the infection rate reduced, the one that the nerve left, like olfactory receptor left, they regenerate. Okay, they regenerate and then they start to connect back with the olfactory or in the cells, and then in the olfactory cells. And then when they regenerate and they start to connect with each other, some of cell, they go to the wrong plug. That means if let's say plug A is for plug A, and then plug B is for plug B. But this receptor, when they start to connect to each other, the plug A go to plug B, and then plug B go to plug A. So because of this, this one is postulation by, there are few studies on this. So once there is a wrong connection, they will have parosmia. That means when they eat eggs, they don't smell of egg. They smell of rotten egg. When they eat bread, they don't smell of bread. They smell of smoke, is a burnt bread. It's like that. So this one is one of the symptoms of COVID-19 patients. Few of my patients have this as well. It's not related to SLE. I think it's based on the study. It's related to COVID-19 because the cells are big.
But from the history, the patient already returned the smell function into the normal condition after she lost her smell. But after that, a few weeks later, she developed smell disorder again, Prof.
Yeah, because when patient has during the diagnosis, patient had anosmia, right? Dewi, patient had anosmia,
yes.
right?
Yes, yes.
Patient had anosmia. That means there's some the olfactory neurons or olfactory receptor affected. It's already affected, and after that the receptors regenerate and they start to develop all these receptors connection. But when patient complain of like maybe after 2 weeks, patient said the olfactory function recovered fully, right? Dewi, right?
Yes,
fully. But that one is on the patient's perception. If we do the test, I don't think patient. But we do the test. I don't think patient has a normal smell. Patient will have hyposmia. But patient didn't realize it. I'm not sure that the one this one I'm guessing because we that's the way how the pathogenesis occur.
Yes, Prof. I agree with you. So I think this patient not return in the normal condition, but she feel normal, but we don't have any objective testing, so we don't sure that the olfactory function is returned to normal or not. Okay, thank you, Prof.
Yeah, thanks.
So maybe one more question, Prof.
Yeah.
From Dr. Young Doctor Eva Nur. She asked about COVID-19. Is it true that anosmia is a good prognostic sign for COVID-19 patient? How about that, Prof?
Anosmia is a good prognostic sign for COVID-19 patient. I think no, because if you ask me, parosmia is a good predictor for a COVID-19 patient. Because why? If patient have anosmia and after that patient have parosmia, that means it shows that basically the cell is regenerate, but the connection is wrong. So this like parosmia, it will disappear with time. But if patient has anosmia and then patient didn't regain the smell, that one is a bad prognosis. But anosmia is not. I think anosmia is not a predictor for a good prognosis. Parosmia, yes. Parosmia, that means patient has some regeneration of their receptor cells.
Maybe the question is the prognostic sign for general condition for COVID-19 patient, Prof. Often we found that COVID-19 patient with mild symptoms have developed smell disorder, but in severe COVID-19 patients, they don't develop smell disorder. Is it true, Prof?
I'm not sure that, but based on my all this research on my patient, it doesn't show like that. So if patient have anosmia, usually they will have prolonged their symptom will be prolonged. They can have this up to 2 months or up to 6 months. But patients who have hyposmia, they regain their function within 2 weeks. But most of patients with anosmia, they regain the function within 2 weeks as well. But some of them, the symptom persists till 2 weeks or still 2 months or 6 months. I'm not sure the work study. I'm not sure if they, if they found that the anosmia is a prognostic factor. Maybe this one, I think maybe anosmia, the isolated anosmia. I think like the isolated anosmia, patient don't have any symptom. Patient don't have any other nasal symptom, but patient have only anosmia. I think that one is maybe.
Yes, maybe isolated anosmia. Yes, okay. Yes, Prof. This moment we have Dr. Hendra Dewi. She already joined with us as a panelist. Please, Dr. Dewi, if there is any comment.
Yes. Good afternoon, Prof. Asma. Prof. Salina, sorry. Because
we are so familiar with Prof. Asma, Prof. So sorry.
Yeah. sorry. Good afternoon, Prof. Salina. Yeah. And my name Dr. Hendra Dewi. My name like same with Dr. Dewi too. Prof. Salina can call me Dr. Dewi too. Same with Dr. Dewi Pratiwi. Yeah. Okay. Thank you very much, Dr. Prof. Salina. Your discussion is very, very interesting and very good. But I have discussed about vitamin D. About vitamin D, like Dr. Aziz's questions, I think vitamin D can to reduce olfactory dysfunctions symptom, even though it's not significant. Because vitamin D protect against pathogens by exerting important regulatory function on both innate and adaptive immunity. Like if a unit immune system, vitamin D can you decrease dendritic cell and increase macrophage, decrease antigen presentation, and decrease interleukin 6. Yeah, and for the adaptive immune system, vitamin D can decrease T helper 1 cell and T helper 2 cell and the other like cytokine production, interleukin 12, interferon, and like this. And about olfactory training, I think like same with in Malaysia, yeah. How to carry out of olfactory train the place dust in patient twice a day for 12 weeks, which for odors like rose, rose, eucalyptus, citronelle, and egenol. I think all of them is same with in the UKM. Okay, Dr. Prof. Salina?
Yeah. We use citronelle is the lemon, right?
Yes, lemon, rose, and eucalyptus, egenol.
Yeah. The last one just now is what? Yeah. The last one. Citronelle, eh?
Yeah.
I think it's the same. The same.
Clove, egenol.
Cengkeh.
Yeah, that's with twice a day for 12 weeks. Yeah. for olfactory training is, I think, is very good for the smell dysfunction in patients COVID-19. Yeah. Salina, how about irrigation nasal with hypertonic research?
Hypertonic nasal saline
Hypertonic
irrigation.
nasal saline irrigation. Because in the journal, with hypertonic for the COVID-19.
How about hypertonic nasal saline irrigation, Prof? Is there any benefit for COVID-19 patients?
A question to me, right? Because there's loss of connection for a while just now. No.
The connection.
Yes, Prof. Question is,
sorry,
how
Dewi,
about
okay.
Yeah, how about hypertonic nasal saline irrigation, Prof? Is it will give benefit to COVID-19 patients?
I'm not sure whether it will give benefit or not because I'm not using that. Because when I read the IACI guidelines in Europe, right? They developed this IACI guideline that they not recommend us to use spray for inpatient with COVID-19 during the infectivity period. That means during that 2 weeks because it can spread the infection. So because of that, I never use any spray, normal saline spray or corticosteroid spray or any, we have here is betadine spray. I never use that. So I don't have any experience in that.
Yeah. Okay, thank you, Prof. Salina. I think in the journal is a model nasal irrigation for the COVID-19 patient with hypertonic irrigation. The journal.
So there are some researcher use hypertonic nasal saline irrigation for COVID-19 patient, Prof, and it gives improvement to the smell disorder. Is it true, Dr. Dewi?
Yes.
Oh, okay. Okay, doctor. Thank you for the comment, and maybe the time is now is for 2:37. So I see someone raised hand. From Dr. Okay, so we only have 5 minutes. How about one more question, Prof?
Yeah, can.
Okay.
It's okay. Sure.
So, Dr. Oh, the young doctor, Bintang, please, you can start to talk to Prof.
Okay, thank you for the opportunity, Doctor.
Yeah.
Prof. Salina. Introduce, I'm young from ENT Department rotation right now in Moewardi Hospital. I would like to ask Dr. Prof, how did nasal irrigation with sodium chloride help the smelling rehabilitation in COVID-19 patients? And there's rumors, Prof, that if we did the nasal rinse before swab PCR, it will give the false negative result. Is it true? I think that's my question, Prof. For your answer, thank you.
Bintang, can you repeat the first question?
Okay. Okay. The question is, how did nasal irrigation with sodium chloride help the smelling rehabilitation in COVID-19 patients, Prof?
Okay.
Especially in patients with hyposmia or anosmia, Prof.
Okay. I will answer the first question first. So the normal saline nasal irrigation, it helps patient with normal upper respiratory infection or with COVID-19. Yes, it's help patient because when we irrigate the nasal cavity with sodium chloride, it improves the mucociliary function of the mucosa. So it will help patient a lot. So to answer your question is yes. But the thing is, I'm not using. I don't have any experience in patient with COVID-19 because I don't give any irrigation to patient. As part of treatment.
For the safety reason, yes, Prof.
Sorry?
For the safety reason.
For this, basically for safety reason, because it can spread the infection. That's all. It's not like we do is not correct, or we didn't do is not correct. It's up to us. It's up to us how you want to treat the patient. Yeah. So the second question.
Oh yeah, there is a rumor, Prof. Here spreading that if we did the nasal rings before we do the swab PCR or antigen, it will give the false negative result. Is it true, Prof?
Okay.
Can it affect the result?
Yeah. Okay. Thank you, Dr. Bintang. So when we do nasal irrigation, does it affect our nasal swab? Okay, and for me, it doesn't affect, because when we did the study when because our swab we took from nasopharyngeal and oropharyngeal. So when patient has loss of smell, the pathology is at the olfactory cleft. It's basically it's difficult to get a swab at the olfactory cleft, because if not, all the anti-surgeon has to go like be in the ground and do the swab. That's why the easiest one is to do the swab through like nasopharyngeal swab and oropharyngeal swab, because the virus is like the flow of the virus, right, from the nasal cavity, it go to the back, to the nasopharynx and oropharynx. But I think to use the nasal irrigation that will flush the virus, I think is not correct, because the virus is in the mucosa. It's like it's part of the epithelium. So if we flush, I'm not sure. I don't know the exact answer, but I think it won't affect. But the thing is, when we do the nasal irrigation, I'm not sure that nasal irrigation can spread the infection or not. I'm not sure.
Yeah, thank you, Prof, for the answer.
Yeah.
Okay, so it's hoax, Prof. we should not do that. Okay, thank you. I'm so sorry. I'm really sorry that our discussion time is up. Now allow me to summarize today's lecture. So, smell is very important for us because it is a safety issue and it can affect the quality of life. And there are many causes of olfactory disorder. It can be in the nasal cavity, olfactory epithelium, in the brain, or malingering. Smell testing is important to do because it can verify the validity of patient's complaint. And the treatment for smell disorder depends on underlying causes. If the cause is rhinosinusitis, then we can give medical treatment. But if the cause is tumor, the mainstay treatment is surgery. And then smell training is proved to be significantly effective for patients with smell disorder. Thank you very much, Professor Salina, for giving us such excellent and informative lecture, and also all of the participants for being active, participating in this lecture. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Dewi. Is basically I want to say that I'm happy, to discuss with this because I'm learning as well. So I think with the question, like a lot of questions, we each other, we learning from each other, right? So thank you very much.
Okay. Thank you, Prof.
Okay, thank you, Prof.
Thank you,
Prof.
So I can leave or how?
We still have
closing
session, Prof.
Sorry?
We still have closing session.
Yeah. Okay.
Okay.
Yeah.
Okay, thank you for Dr. Dewi Pratiwi and Professor Salina. That was a great presentation and very outstanding explanation from you. So moving along, we have already had expert lecture and discussion. Hopefully that today's lecture would give us some new insights and benefits for all of us, especially in providing medical services to our patients. So once again, I would like to thank to all the audience, to Professor Salina Husain. Thank you, Professor. And then to Dr. Dewi Pratiwi. Yes, thank you, Prof. And to Dr. Sarwasuti Hendra Dewi, Dr. Hadi Sudrajat. Thank you for taking your time to attend this international lecture. So I'm sorry, before we end this lecture, we will have another photo session, maybe for the last time before we end this lecture. We will take the photo session again. No, okay. So we don't need to.
I think
okay. So
that's okay. That's okay. We will take once more photo session, Prof, in the end of the session.
Okay. So I will count 1, 2, 3. Okay, maybe this is the last one. 1, 2, 3. Okay, thank you. So this is the end of our lecture. I would like to apologize if there are any mistakes, and it is my pleasure to have the opportunity here. I sincerely appreciate for your attention today. Okay, last but not least, sorry. Okay, last but not least, I just want to say, keep your spirit in exploring the knowledge and keep up the good work. So goodbye and see you on the next international guest lecture. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Salina.
Thank you, Prof. Salina.
Thank you.
Send our regards to Prof. Asma, Prof. Go, Prof. Marina, Dr. Dina.
They know that I'm giving lecture today.
Oh. Hopefully we can meet soon, Prof.
Yeah. For 2 years, we don't travel anywhere.
Yeah, it's true, Prof. Thank you, Prof. Stay safe.
Yeah, so I can leave or I stay?
Okay. You can leave now. Thank you.
Thank you very much, Dr. Dewi. And
thank you very much.
You're welcome, Prof.
Nice to meet you all. Even though we can see only face.
Yes,
okay,
Prof.
Thank you very much. Okay, bye.
Welcome, Prof.
Welcome. Thank you very much. In next years.
Ya, Prof. Terima kasih, Dok, untuk undangannya. Izin live ya.
Ya, Dokter Ana.
Dokter Ana.
Dan lain-lainnya. Iya, alhamdulillah sehat.
Makasih ya.
Sehat live dulu ya.
Sehat ya.
Sukses terus.
Ya, amin.